Hello, everybody. Welcome to today's webinar. Today, we're going to learn about commercial tobacco cessation intervention training, specifically Ask, Advise, Refer. This is an introductory level course, and it's a brief intervention. Before I continue, I'd like to cover some of the differences between cultural and commercial tobacco. Cultural tobacco is considered sacred among many American Indian peoples. It's considered a gift from the creator. It's not genetically engineered to produce more yield or nicotine or a different flavor. It can be used in ceremonial purposes, such as to carry a prayer up to the creator. It can be used medicinally as a painkiller or as an offering as a sign of respect or thanks to a healer or elder. By contrast, commercial tobacco contains harmful chemicals, about 7,000 of which hundreds of which are harmful, and about 70 that cause cancer directly. They come in many forms, like cigarettes, cigars, e-cigarettes, hookah, smokeless, or chew. And that includes the variety of all the different kind of e-cigarettes that are in the market now. So screening methods. Today we're going to be focusing on Ask, Advise, Refer. This is a quick method, and one of the key differences between this and the 5 A's is that it does not necessarily require a follow-up. But with 5 A's, there is a follow-up, and the 5 A's are Ask, Advise, Assess, Assist, and Arrange. This model, the person that's doing the counseling would be you. You would be the one that has to do the quit plan and arrange for follow-up and all of those different aspects. With Ask, Advise, Refer, however, you can hand off the patient to someone else to do the counseling. And the one that works best for you is up to your organization. Maybe you aren't set up to do in-house counseling, or maybe right now you can't do in-house counseling because a lot of the in-person services are limited. So you could refer something to like the California Smokers Helpline, which does most of their work over the phone. So what is Ask, Advise, Refer? So if we can, on one side of the screen, if we can put a check mark using the annotation function, we'll put a couple of check marks on the screen for those who have experience and some X's for those who maybe this is new to them. Okay, it looks like there's a little bit of both. And today we're going to have our participants take part in the script that I have for you today. And so we're going to be practicing this. I'm going to go ahead and clear the screen, and we can continue. All right, so Ask, Advise, Refer looks a little bit like this. This is a script from Sacramento County. They have adapted their script using some guidance from the American Lung Association. If you are one of the X's that has not had so much experience, you can read directly from the script and follow all the prompts. So today we're going to practice a yes, I am ready to quit scenario, and a no, I'm not ready to quit scenario. The sneaky trick here is that regardless whether they say yes or no, you're still referring them to the helpline. And that's what we're going to use in today's example. So do you currently use tobacco products is the first question. You can say, do you currently use any nicotine products? Do you currently smoke or vape? And those kinds of questions are more encompassing of all the different products that there is out there. If you just say, do you currently smoke? They might say, no, I don't, but they could vape or chew. With our particular population, you can ask, do you use commercial tobacco products? But you can just say tobacco products, and then if they say no, you can follow up with a ceremonial use if you want, depending on your clinic or organization. So if yes, have you thought about quitting? If they have, and if they're interested in quitting, quitting isn't easy, but it's possible, and it's one of the best things you can do for yourself and your loved ones. and then you do the referral, which is, in this case, the California Smokers Helpline, and you can follow the prompts. The other way, if they say no, or yes, I do smoke, and no, I'm not really willing to quit, you can say something like, it can be a little bit daunting, but it's one of the best things you can do for yourself and your loved ones. If you're not ready to quit, that's fine. Here's some information for when you are ready, if you'd like to come back, or if you'd just like to get more information. Here's a card to the California Smokers Helpline. Okay, so these are known as the 5 R's for motivation. And so you can use these to increase your patient's own willingness to quit. Or we can move them to a different stage of change. So if they're not thinking about it, perhaps all we are going to do in our efforts is getting them to start thinking about it. And on the next visit, maybe from thinking about it to actually taking action. But how we do that is by enhancing their own motivation to quit. And how we enhance their motivation to quit is by using some of these 5 R's as our tools in our toolbox. So we want to make our approach relevant to them. And the 5 R's are relevant, risk, reward, roadblocks, and repetition. Risk is informing them of their risk. Perhaps they aren't aware of them. Maybe they have been smoking for years, and maybe their parent and grandparents smoked also, and none of them got cancer. Their odds would be incredibly lucky to have all of them not get cancer. But if that's the case, maybe they think, well, it didn't really hurt any of the people I know. But explaining these risks might get them to move towards thinking about quitting. If they don't care about that risk, and they do know about it, a different way to approach it might be with a reward phase, so health benefits or money benefits. So if you're a pack-a-day smoker and you quit smoking, you'll save $10,000 a year. If this is someone who is struggling with money or is living paycheck to paycheck or on a tight budget, having an extra $10,000 a year might be motivation enough to begin that quit phase, or at least get them to start thinking about it. Roadblocks are going to exist for many, if not all, of the people that you're trying to help on their quit journey. And with roadblocks come in different shapes and sizes. One common one that I like to use is if they have tried a lot of times and they're just like, you know what, I'm very irritable every time I quit. I'm incredibly, cranky, and I'm mean to my wife every time I try to quit, and I don't want to do that to her, and I don't want to put her through that. So I'm just not going to try that again. I've tried it like 4 or 5 times and it didn't work. So this is a real concern, and it's a real roadblock. And our job would be to help him overcome the roadblock, or give him a tool to try to meet that challenge. For example, you can introduce nicotine replacement therapy if they haven't already tried that, which would help reduce the cravings and reduce the mood swings, so that they can practice the behavioral change of not smoking and be a little bit less irritable and a little bit less aggressive or moody towards their loved ones. Repetition is pretty simple. It takes on average 8 to 12 tries before a successful quit attempt, which is defined as being successfully quit for 6 months or more. And so in the example that I used during the roadblocks, if they tried 4 or 5 times and they haven't been successful, that doesn't mean that they have failed, because as you can see, it takes 8 to 12 tries. So they are on their quit journey. And even if they've hit 12 tries, that's on average. So it takes multiple attempts, and each one is a learning experience. So that will help people that feel like they've tried everything know that, first of all, no, they haven't, and second of all, multiple attempts is normal. So here is the stages of change model that I mentioned earlier. It's also known as a trans-theoretical model for behavior change. They're used interchangeably, so it's the same model really, and that operates on this construct, which is that there's pre-contemplation, contemplation, determination, action, maintenance, and recurrence, or in our case, relapse. This can be used for any behavior change, but we'll use it as the behavior of anything other than smoking. So that's what we're trying to change. What they end up doing is up to them, right? If they stop smoking but begin, I don't know, walking or running, that's the behavior change we're looking for. So pre-contemplation is where I get the most questions. This is where you get the hostility from people, the I'm not willing to quit, don't ask me, leave me alone, those type of questions. So those people are in the pre-contemplation phase. They're not willing to quit. And our primary goal there would be to raise awareness using those 5 R's to get them towards the contemplation stage, which is thinking about quitting. Those are the pre-contemplation phase. We're not going to get a quit date out of them or even an answer. We'll probably get hostility, and that's not what we're going to do, because if someone doesn't want to quit, we're not going to make them change. Our goal is to get them to want to change themselves. So if we increase awareness, and after a while they start thinking about it, they have moved to the contemplation stage. And in this stage, there's usually something that is blocking them from wanting to change still. Like this might be where the roadblock example existed, where they're like, man, I'm thinking about it, but I don't know if I should go about it. I get really irritable every time. So what we do here is try to resolve the ambivalence or resolve the reason why it is that they are still kind of on the fence about it. So whatever challenge or roadblock that they have, this is where we can try to move them towards determination, towards making that decision like, yeah, you know what, I do want to quit. And then they're in the determination stage. And if they do want to quit, perhaps they still don't know how, or they have already tried and they're back and they're motivated and they want to try, but now they need your help. So the determination and action phase, today we would focus on referring them somewhere. But if you were the cessation counselor, this is where you would do the quit plan and talking to them about the different medications there is out there. If you're a provider, this is probably where you would prescribe like Chantix or Zyban, for example. And we'll get into all the different NRTs here in a moment. But I did want to cover all of the tools in the toolbox before we practiced. So determination, that's where they're willing to quit, but you're going to help them in that goal, or you would refer them to the helpline and someone would help them for that stage. Action is when they've already began their quit journey. They've already had a quit plan and set the quit date, and they are attempting it. And they might come back and say, hey, I'm here because I already tried to quit, and it's really hard. I don't know, can I get, maybe they're on NRT that's over the counter and they want a prescription, and maybe they're quitting, but they need a little bit of extra help. Or they've already quit and they've been quit for, a couple days, and they might need support. Maintenance, that's just they've been quit for a while. This is where you would congratulate every time you come and ask. They would say, no, I used to quit, and so or I used to smoke and now I quit. And this is where we would congratulate them for their efforts. Recurrence or relapse, that's if they end up going back to how they were smoking before. If they accidentally or are out at the bar with some buddies and they have one cigarette and it's a slip, that is different than full-blown relapse. Relapse is more of going back to the way they used to smoke. So if they smoked a half a pack a day and they quit and then they go back to smoking a half a pack a day, that's relapse. If they just have one, then it's that's considered a slip. Okay, so all this referral info to the helpline, I'm not going to cover UC quits right now, but that would be information to have a kind of a flow chart for clinics to try to delve into how they would all collectively refer patients. In this example, I'm using the California Smokers Helpline. So this card down here that says take charge, this is the card that you would hand to people, and it's also the number that they would call. It has the website on there as well. You can have about 3,000 of these for free if you call the helpline, and they will help you or they'll just mail them out to you. They also have some that are native specific. So the number is 1-800-NO-BUTS, and the website is nobuts.org, and they will do the cessation counseling for you if you refer them there. They have a couple of different referral options. So telephone counseling is their bread and butter. This is where they really focus a lot of their efforts. They have text messages that they can send to you during the times where it's the most difficult, or where you have identified that you're going to have the strongest cravings or withdrawal symptoms. They have a mobile app, so you can have your quit plan with you at all times and use different resources on the app. They have county cessation program listings, so if you need to refer someone to an in-person, I know that's a little bit difficult right now with all the different closures, but this is a resource that you can use to find that. And they also have free nicotine patches for anyone that is trying to quit and has someone in the household that's 5 years and younger. And for a limited time, they also provide it to anyone else that has called the quit line and has set up a quit date. They'll mail you out nicotine patches. They also have an online referral interface. So if you're a clinic, you can register your clinic, and then every time you want to refer someone, you can put their information into that interface, and someone from the helpline will call the patient. That way you don't have to worry about whether or not the patient did go through with it and end up calling the helpline. Even if you hand them that card, they might just, you know, lose motivation or lose it, or say, you know what, maybe I don't want to do it. But this way, if you set it up, someone will call them and get a hold of your patient or loved one. So what happens when you call? I'm not going to get into this too in depth. The main takeaway is that you don't have to quit smoking when you call. Right when you call, they're not going to force you to quit again. No one's going to quit unless they want to quit, and we can't force anyone to do it. So that expressing that with your patients or loved ones is sometimes a relief, because you have some anxiety about whether or not you're going to quit. And if you feel like they're going to make me quit as soon as I call, you might be feeling like you're not ready to make that decision yet, so you don't make the call yet. That takes a lot of the anxieties out, knowing that you're not going to have to quit. You can call for information, you can call for someone else, you can call for when you are ready, you can call to set a quit date and to have them follow up. All of these are valid. Okay, so there's a couple of different quitting methods. So there's cold turkey. This is not a food. This is a method for quitting, which means you're not using any cessation medications or any behavior counseling. You just wake up one day and say, I'm not smoking anymore, and then you actually don't smoke ever again. So this method works for about 5% of people or less. The good news is that of those who quit using this method, most of them stay quit for the rest of their lives, because it was incredibly difficult to do and they don't want to have to go through that again. Gradual, I recommend this option the least. So there's two different kind of subcategories, which are tapering and postponing. Tapering, I would maybe only recommend if you're a very, very heavy smoker or vapor, and maybe you smoke 3 to 5 packs a day, and you're going to want to taper down to maybe 1 before you have your quit attempt, so that you don't go from having an incredibly high level of nicotine in your blood to no nicotine in your blood, because those withdrawal symptoms are going to be very strong and difficult. So even using NRT patches might still be tough. Postponing, I almost never recommend. Postponing is, 2 examples are like when people say, I don't smoke at home, I only smoke when I'm at work or something like that, so they don't expose their family to secondhand smoke, but there is still third-hand smoke that exists in their clothing, and when they come home, where they are still exposing their loved ones to secondhand and third-hand smoke. Another example of postponing is when a pregnant mother quits smoking while they're pregnant and then begins smoking again after the baby is born. I don't recommend that at all. But of course, either one of these methods, less smoking or vaping, is better than more. So any effort, I guess, would be commendable. pharmaceutical aids include your nicotine replacement therapy and your non-nicotine replacement therapy. And I'll cover those right now. On the left-hand side here, you'll see your nicotine replacement therapy options, and down horizontally on the right-hand side are your non-nicotine replacement options. There is nicotine lozenges, nicotine patches, and nicotine gum. These are all available over the counter, which means that you can go down to Walmart or Target or Walgreens, CVS, etc., to just buy them. You don't need a prescription so long as you're 18 and over. The lozenge is very simple. It dissolves in your mouth and it absorbs in your gums. And the nicotine patch comes in a couple of different strengths. So there's a lighter version and a stronger version. The rule of thumb is that if you have to smoke your first cigarette or take your first vape within 30 minutes of waking up, then you would use the stronger version of the patch. This is known as slow-acting nicotine replacement therapy, which means it releases slowly throughout the day, and you can use it in combination with what's known as a fast-acting nicotine replacement therapy, which would be the gum or the lozenge. And so the patch, you just put it on first thing in the morning, you take it off at night. The nicotine gum, you use the chew and park method as opposed to just chewing it like regular gum, because that might just give you a tummy ache, and if you eat enough of them, you'll probably throw up. And that's because nicotine is not absorbed in the tummy. It's absorbed in your lungs, your gums, or through the skin. So you would chew it, park it on one side, let it absorb, and then you would chew it, park it on the other side of your mouth and let it absorb until you've received the amount of nicotine that you wanted. Even though these are known as fast acting, the lozenge and the gum are known as fast acting, they're not as fast acting as as a cigarette, for example. These will take about a minute to 5 minutes to kick in, and a cigarette takes about 8 to 10 seconds. They're also not as strong, so we recommend taking these on a scheduled basis and not an as needed basis, because a craving is going to last about 10 minutes. So if it takes 5 minutes for these to kick in, you're already halfway through your craving, which would increase your chances of relapse or an unsuccessful quit attempt. So another question I get is, why are we giving nicotine to people that are trying to quit nicotine? And that is because this is only nicotine. It doesn't have any of the other harmful chemicals associated with cigarettes or vaping. And even then, they're not considered, they're not supposed to be used permanently. They're just used to reduce the nicotine withdrawal symptoms and cravings, so that you can focus on a behavioral change that'll lead you away from all the different types of nicotine that's used commercially. Again, there's a difference between the commercial and cultural tobaccos. The bottom two on the left are your nasal spray and your inhaler. They're used much less often. They are by prescription only. The Chantix and Zyban, those are your non-nicotine replacement therapies. Chantix blocks nicotine receptors in the brain and body. One way to use this is you smoke or vape regularly for about a week, and then when you get to the end of that week, you would start your quit date. But that whole week you would be taking Chantix, and it'd be blocking the nicotine receptor. So when you get to your quit date, theoretically, it's easier for you to start your quitting process. Zyban is also known as Wellbutrin, and it was used originally as an antidepressant, and it happened to be used well for tobacco cessation. So you can combine the Zyban with the nicotine replacement therapy, so you can do a patch and gum and Zyban all at the same time. It seems to be a popular combination to prescribe to patients. Again, the Zyban and Chantix are by prescription only. These are some quitting benefits. So within 20 minutes of quitting, your blood pressure decreases. So if you struggle with high blood pressure, this is a good way to reduce your high blood pressure. Within 3 days, the nicotine will be out of your body. 1 to 9 months, the cilia will start growing back. The cilia is the little tiny hairs in your lungs and in your throat that helps you clear your throat every 2 minutes, whether you like it or not. See? So that'll all start growing back. And what will also happen is that because it's growing back, it's going to start getting all of the tar and all the gunk out of your lungs and your throat. And so what's known as smoker's cough might get worse before it gets better. And for the most part, that's normal. In about 1 year, heart disease risk reduces about 50%. So let's practice. I have a few participants here that are going to help me do the asking, advising, and referring portion. So we're going to go back to our cheat sheet here, and I'm going to be the patient for the yes, I'm willing to quit, and then we'll try it again with a new person, and I'll be the not willing to quit, and we'll see how either way I get referred to the helpline. So let's start with Adriana. Would you like to be the doctor today?
Sure.
Okay, whenever you're ready.
Okay. Hello, how are you doing?
Doing good.
Good. I wanted to check in and see if you're currently using tobacco products, including smokeless or cigarettes or vaping products.
Yeah, I smoke.
Have you given any thought to quitting in the future, or do you have any concerns about that?
Yeah, I've been thinking about quitting.
I know that it can be overwhelming to think about quitting, but it's the best thing you can do for yourself and your loved ones. Do you have concerns about your health?
Yes.
I can definitely connect you with the California Smokers Helpline to get some free resources and information to help you learn more about quitting. Would that be helpful to you?
Yeah, I would like that. Thank you.
Sure. I'll put a note in your chart here, and we'll connect you with those services so that you can get the support that you might need for the next step.
Awesome. Thank you.
Sure.
Good job, Dr. Adriana. Dr. Julie, Dr. Via, would you like to go next? And I'll be unwilling this time, and you can go down that script for us.
Sure.
Whenever you're ready.
Hello, Ephraim. How are you doing today?
Doing good.
I just wanted to ask you, do you currently use tobacco products?
I do. I vape.
You do. Have you thought about quitting in the future, or are you wanting to quit?
Nah, I enjoy vaping, so I don't really want to quit right now. I think it's good. It's fine anyway, right?
Well, it can be a little daunting, but quitting is the best thing that you can do for yourself and for your loved ones. And quitting isn't easy, and you have to be ready. So I'll check back with you again in the future, and you can always reach out to me if you want to talk about it. But would you mind if I refer you? And here are some resources so you can learn some more.
Okay, cool. Thank you.
You're very welcome.
Awesome. All right. Thank you to our participants. So either way, that there's a yes, I am ready to quit, and a no, I'm not ready to quit. Either way, we're handing them off to a referral. And the no person might just say, cool, I'm throwing this away, or they might not, they might hang on to it. But if we don't do that, then they'll never have that option. So this can be done in many different ways, and you eventually get your own flavor and your own rhythm. But I hope that this was helpful. And this kind of concludes our training for today. Here's a couple of different resources, notably the California Smokers Helpline, the National Native Network, which I'm the California representative for the National Native Network. If anyone wanted any trainings or technical assistance, and also the California Rural Indian Health Board, which is bringing you the training today. If you have any questions, feel free to reach out to me. Thank you very much.